For many, many years, there is the myth that women and girls should not be participating in athleticism or intense exercise because it was somehow unhealthy for them or unladylike. But we now know that's obviously not true. And in the past 40 years or so, girls and women have done some amazing things with athleticism. There are still sex differences when you look at the actual performances of men versus women or of girls versus boys. This is partially due to biology, but also there's still some social factors that are to blame for some of this. So cultural factors and a little bit of a suppression of women in athleticism. The sex differences, so when you're comparing sex differences like I'll be doing in several videos in this playlist series, it's generally thought of as unfair to compare women and men who are both untrained because there's a much larger difference in untrained men and women than there are in trained men and women. Generally speaking, untrained men tend to be a little more physically active than untrained women. So when you're trying to figure out what the difference in the capacity of men and women are, it's much more fair to compare trained men and women to each other rather than the untrained. Of course, if you're trying to figure out what the average man and the average woman is, then you should also include untrained men and women in your samples. But again, the comparison between men and women is much more fair if you're trying to just figure out what the difference is between maximum capacity when you're looking at trained or especially elite trained individuals. When discussing the basics of what is different between men and women for their athletic and exercise capacity, as well as just their body structures, you have to bring it back to the basic mechanism. So that is the differences in the primary sex hormones of men and women. So if you look at this figure over here, we have the stages of puberty and then adulthood. We have estradiol, which is the primary estrogen that women have, and we have testosterone in the blue. And you can see the dotted lines are women, the solid lines are men. Women have very little testosterone. It does increase throughout the stages of puberty into adulthood, but there's still very little compared to men. If we look at women for estradiol, the dotted red line here, it skyrockets during the stages across the stages of puberty into adulthood. They have a lot more estradiol than men do. Looking at the solid lines now, the men, the blue is the testosterone line. As you can see, again, the men have a lot of testosterone, a lot more than the women have, and they have much less estradiol. They do have estradiol, and it does increase with puberty, but it is much less than what it was seen in women. So the primary difference between men and women, then, men have a lot of testosterone, women have a lot of estrogen, and not vice versa. So testosterone leads to increased bone formation. So we have larger bones. We also have thicker, typically denser bones. We have increased protein synthesis. This leads to greater muscles. We have greater erythropoietin, EPO, which is the primary hormone that drives the production of red blood cells, so that carries with it hemoglobin and oxygen carrying capacity within our blood. Women, on the other hand, with their higher estrogen levels, have higher fat deposition, so this leads to higher body fat percentages in general. This is especially true when you look at the thighs and hips, which is why generally when women become overweight and obese, most of the weight goes to their thighs and hips. It's a little different from what it is in men. And this is because they have higher amounts of lipoprotein lipase in those areas of the body, which synthesizes the fat. Women also tend to have a faster growth spurt at the earlier stages of puberty. So young girls are usually taller than young men or young boys, but women's growth plates tend to close a little earlier than men's growth plates do, so women tend to be shorter than adult men. This was just a general overview of some differences between men and women driven by their different sex hormones and how that may affect exercise performance. We'll talk more into the details of this with coming videos where we're going to talk about strength differences and muscular differences, as well as cardiorespiratory and metabolic differences in women compared to men. Differences in sex hormones between men and women do lead to differences in muscle strength. So looking at the strength of the upper body, women tend to be 40 to 60% weaker than men. The lower body, they tend to be 25 to 30% weaker than men. The difference between upper and lower body is because women tend to be more active with their lower body. Everybody uses their lower body to walk around, go up steps, things like that. upper body tends to be less active unless you're purposely being active or engaging in exercise or athleticism in some way. In general, women do a little less physical activity in sports than men. Of course, that's not the case for everybody, but in general, on average, that is the case, especially when you look into adulthood. The reason why there's a difference in strength between men and women, it doesn't have to do with individual muscle cells and how they function, but has to do with the cross-sectional area of the muscle. So if you were to compare men versus women with equal cross-sectional areas of the same muscle, you would find the same amount of strength between men and women. This is not a perfect comparison over here because I'm not looking at cross-sectional area, but this is collected on my own students. And you can see that there's a linear relationship. In general, men and women are the same strength if you look at the same size of the muscle. Resistance exercise training is really important for women. Women tend to suffer from lower bone mineral density than men, especially when they get into older years, postmenopausal especially. And resistance exercise is really good for maintaining or even growing bone mineral density and improving the strength of your bones. This is also important because traditionally speaking, women were much less likely to participate in resistance exercise than men. Nowadays, it's a little more equal between men and women with resistance exercise training, but it's still a slight discrepancy between men and women. The strength gains that are seen between women and men are a little different because of the lower testosterone level that women have compared to men. They end up with less hypertrophy when they do resistance exercise, but they compensate with higher amounts of neural adaptations. So they do gain strength. They do gain the ability to move and produce forces at higher levels, but they do it less with hypertrophy and more with changes in their nervous system. There are also differences between men and women for cardiorespiratory fitness as well as metabolic fitness. So I'm going to cover that in another video, so make sure that you watch that as well. The difference between men and women for their responses to cardiorespiratory training, so we're talking about aerobic exercise, is essentially zero. There is no difference between the training adaptations. However, there is a difference in their baselines, and so that does continue through training. So discussing respiratory function, larger lungs in men, this is driven by larger body. So in general, the larger the person, specifically the taller the person, the larger their lungs are going to be. It just makes the thoracic cavity where the lungs sit bigger, and that allows for larger lung development. Talking about cardiac function, similar, we end up with larger hearts in men than women because they have larger bodies. But how does that affect cardiorespiratory fitness and cardiorespiratory function? If you were to take a man and a woman with the same age, the same training status, and you had them do the same submaximal aerobic workload, so both on a treadmill, maybe 5 miles per hour, 2% grade, you would find that the cardiac output between men and women was approximately the same. All right, so if we look at this figure over here, we're seeing cardiac output being approximately the same between the women and the men, so the men being the blue bars, the women being the red bars. However, how they get this cardiac output is different. Stroke volume tends to be higher in men than women, so men are going to have a higher stroke volume than what women do. However, women are going to compensate with higher heart rates than men. So women have higher heart rates, men have higher stroke volumes. Stroke volume times heart rate gives you cardiac output though. So at submaximal exercise intensities, this level of compensation is possible and you end up with the same cardiac output. These differences are driven by the larger hearts of men because men tend to have larger bodies. Larger hearts, larger stroke volumes, less heart rate necessary to reach the same cardiac output. There are also some subtle differences between men and women for aerobic metabolism, so VO2 or oxygen consumption. So if we're looking at the same submaximal workload, again, 5 miles per hour, 2% grade on a treadmill, both a man and a woman doing that, the relative VO2 would be about the same between men and women, just like the cardiac output was about the same between men and women. But also like cardiac output, we're going to get to that differently between men and women. Men have a higher oxygen carrying capacity of their blood because they have higher hemoglobin, and women are going to rely more heavily on AVO2 difference, so arterial venous oxygen difference, which basically means they're going to extract more of the oxygen that comes to their muscle than what men do. This is a compensatory mechanism for the lower hemoglobin levels. All right, so Both are able to do the same exercise intensity at a submaximal level. They get about the same relative VO2, that is in milliliters of oxygen per kilogram body mass per minute, but they do so slightly differently. There is a difference between men and women for maximum oxygen consumption. Again, this is in milliliters of oxygen per kilogram of body mass per minute, so this is relative VO2 max that we're talking about. Men tend to have higher VO2 maxes than women do. There are a few reasons for this. We're going to start with the reasons with the lowest impact on VO2 max and work our way up to the highest impact on VO2 max. So the lowest of the three reasons, women have lower hemoglobins than men, hemoglobin concentrations than men, which means per unit of blood, they have less oxygen. A more moderate impact is women have lower cardiac output max, so cardiac output at maximal exercise than what men do. This is driven by a lower stroke volume at max because they have smaller hearts. They have equal abilities to increase their heart rate during maximal exercise, so it's really the stroke volume that is the difference here. The factor with the highest impact on VO2 max between men and women has less to do with physiology, more to do with how we calculate relative VO2. So we do milliliters of oxygen per kilogram of total body mass per minute. Because women have a higher body fat percentage, that means a higher percentage of the weight that they are carrying is fat than men, and that fat is less metabolically active, so it's often called metabolically dead, and it is less functional, so it is not muscle weight that can produce force and consume oxygen at high levels. So when we're making relative VO2 relative to total body mass, there's a giant difference between men and women. When discussing women and their participation in exercise and sport, there are some special considerations like menstrual dysfunction and pregnancy that we need to also discuss. I'm going to be putting those into additional videos, so please make sure you watch those as well. Exercise-induced menstrual dysfunction is something that's specific to women because only women have menstrual periods, and we're going to discuss that in this video. First off, I just want to say that menstrual dysfunction does not equal infertility. That's a common myth, and that's something that is potentially dangerous for somebody who's not ready or willing to be pregnant at this time to think, so I want to make sure that we say that up front. All right, looking at this figure over here, we're not going to go in a lot of detail about this, but this is showing the typical 28-day menstrual cycle in women. We start with the menses, which is the period. We then go into the follicular or the later follicular phase. We have ovulation approximately in the middle, and then we have the luteal phase towards the end. And you can see the differences in hormones. There's a lot going on here. So the hormones are driving all of this. All right, but we're not focusing so much on the menstrual cycle as much as menstrual dysfunction here. Eumenorrhea is the term used for normal menstrual cycles, which are typically occurring, having a period occur every 28 days. So a restarting of the menstrual cycle every 28 days. Oligomenorrhea is the term used for irregular menstrual cycles. The definition varies. This can be more sporadic menstrual cycles. So it can be one is 28 days, another one's 36 days, then you have 24 days, and they're kind of all over the place. Or it can be that you miss some menstrual periods and then you get other menstrual periods. So it might be a missing of some, but not all, or it could be just an irregular length of time that is unpredictable. All right, and then amenorrhea is the complete absence of the menstrual period. This is the lack of menses. Amenorrhea is often caused by energy deficit, so too little food intake for the amount of exercise being performed. Menstrual dysfunction is much more likely in lean physique sports. There's a number of sports that fall into that. We'll talk about that in a minute. The actual percentage of women athletes who have menstrual dysfunction, so oligomenorrhea or amenorrhea, varies depending on the definition of oligomenorrhea. So anywhere between 5 and 66% of female athletes do have irregular menstrual cycles. Again, this depends on how you define irregular, which is the reason why there's so much range there. So even if you were to kind of cut in the middle, somewhere probably around 40 to 50% of female athletes, it's almost half, do have irregular menstrual cycles. There are a number of issues with having irregular menstrual cycles. One of the biggest one is its effect on bone density. Bone mineral density can be increased or maintained with a proper diet and weight-bearing physical activity, which is something that all women should be striving to. Men should as well, but it's especially critical for women because they're more likely to develop osteoporosis later in life. Typically, maximum bone density is achieved pretty early in life, so around 30 years old. After that, it tends to slowly drop off over time. And the goal at that point is to protect the bone density you have so that you don't become osteoporotic when you're older. Exercise can protect against bone mineral loss that occurs postmenopausal. So it is important for women to exercise both when they're young to build up bone mineral density and when they're older to prevent further loss of bone mineral density. It is important to consider the relationship between normal menstrual cycles and bone mineral density. So if we look at this graph over here, these are women who are always having regular menstrual cycles. These are women who have sometimes irregular menstrual cycles, and this is women who have always irregular menstrual cycles. So regular down to always irregular with the sometimes irregular in the middle. We have bone mineral density on the y-axis. We can see that there is a statistically significant drop-off going from always regular to sometimes irregular, and then another one from sometimes irregular to always irregular. So the regularity of your menstrual cycle does indicate the level of bone mineral density that you will have. This is driven by having an appropriate diet with the appropriate amount of calcium and vitamin D, as well as calories, to allow our bodies to build and maintain bone minerals, and having weight-bearing exercise that's going to promote that growing and building of bone minerals and bone density. So it's important for female athletes and exercising women to make sure that they are eating properly and they're not experiencing energy deficit, or especially excessive energy deficit that might lead to amenorrhea, because it will affect bone mineral density. In another video, I'm going to talk about some basic information about eating disorders, which is also very prevalent among female athletes, and it's something that will affect your menstrual cycle as well as your bone mineral density if it's not corrected. So please make sure to watch that as well. Unfortunately, eating disorders are prevalent amongst young women. It's especially true amongst young female athletes. There are two primary eating disorders that I want to discuss here, and we're only going over basic information. This is not enough to treat women that may have these or even identify the women who do. That is not the purpose of this video. You need a lot more information, a lot more training and education to be able to do that. Anorexia nervosa and bulimia nervosa are the two types of eating disorders we're going to discuss here. Anorexia nervosa, or anorexia for short, is the refusal to maintain minimal normal weight. The common features of this are distorted body image and fear of fatness. Amenorrhea is very common, so loss of menstrual cycles, and dramatic weight loss. Bulimia nervosa is a purging behavior that typically occurs after meals and prevents weight gain or proper weight maintenance. And so this has a lot of the same features we discussed up here, and this is not a full list of the features for either of these conditions. There are far more symptoms and features or warning signs that you should be aware of that we're not going into here. People with bulimia often have recurrent binge eating, so they eat a lot of food, and following binge eating, purging behaviors often occur. So this can be vomiting, this can be laxatives, diuretics, or excessive exercise. Those are all forms of purging behaviors that can decrease the weight of an individual after they have consumed a substantial or even normal portion of food. Some additional information about eating disorders. Young women have the highest prevalence. This includes young female athletes. But young men do also have the risk of developing eating disorders as well. Certain sports do tend to encourage this behavior more, and they should be more careful about wording and sort of team atmospheres. Aesthetic sports, so think diving, figure skating, ballet, gymnastics, cheerleading as well. Endurance sports, distance running, cycling, weight class sports, jockeying, boxing, wrestling, all those have high prevalence of eating disorders. Some additional information about eating disorders is that they are addiction disorders. So this is a psychological disorder requiring psychological counseling and help. The behavior is often reinforced by the media, by their parents, their coaches, and teammates. So you want to be careful about how you interact with your athletes and the people who look up to you or who you have in some way that are within your care. They can often be accompanied by denial, so people who don't believe they actually have an eating disorder, and they can become life-threatening, so it's not something you want to ignore or diminish the importance of. People who have eating disorders, or if you suspect somebody has an eating disorder, they really do need to get clinical help. It is outside the scope of practice of exercise physiologists, athletic trainers, coaches, physical educators in order to treat them. They can look for the warning signs and try to discuss it with the athlete, specifically trying to refer them to a specialist, typically a dietitian and a psychologist of some sorts, but it is outside their scope of practice to actually treat it. In another video, I'm going to discuss the female athlete triad, which may or may not involve eating disorders, and it oftentimes does lead to health consequences, especially bone mineral density issues. In this video, we're going to discuss the female athlete triad, and we're also going to discuss the male athlete triad, which is essentially the same thing, but in men. It's much less discussed, but let's start with the female athlete triad. So the female athlete triad is a syndrome of interrelated conditions, is the energy deficit, hormone dysfunction, and bone mineral density issues. That is the triad. So that's these three here making up that triad. So excessive dieting and or excessive exercise can be the cause. Disordered eating may or may not be involved. Amenorrhea is likely the first warning sign that women are going to experience when they're experiencing the female athlete triad, and that's the reason why there's a lot more evidence on the female athlete triad than what I'm going to discuss next, which is the male athlete triad, because men do not have menstrual cycles to have amenorrhea. So much less studied. The awareness is much lower for this as well. Most people have never heard of it. The female athlete triad results in amenorrhea, and as I discussed, the male athlete triad does not. And so we don't have a monthly check to make sure that this is not occurring in male athletes. The first warning sign, if any at all, happen in males is typically bone fractures, things like stress fractures, repetitive stress fractures occurring. That is a sign that they may have male athlete triad. Regardless of it's the female athlete triad or the male athlete triad, it's energy deficit leading to hormonal dysfunction, which leads to bone mineral density problems. Again, in women, they have amenorrhea that occurs, and so they often have a regular check to make sure that this is not occurring. That and men do not have that, unfortunately. All right, regardless if it's a female or male experiencing the athlete triad, they should get this addressed as soon as possible. Treatment generally involves increased caloric intake or sometimes decreased activity, because the primary cause of this is energy deficit. So too much energy deficit leading to issues with your hormones, leading to these other issues as well. In a separate video, I'm going to be discussing issues of pregnancy and exercise during pregnancy, so make sure to watch that video as well. For decades, we've been hearing about the female athlete triad and on occasion the male athlete triad. Those are basically the same thing, but one's in a woman, one's in a man, and in men, we don't have menstrual dysfunction. But regardless, those terms, both of them, are suggested for retirement by the International Olympic Committee, or the IOC. In place of the athlete triad terminology, it is now recommended that we use the term relative energy deficiency in sport, or RED-S. This is too little caloric intake for the level of physical activity that the athlete or the individual is doing. Okay, so the reason for switching away from the athlete triad terminology to the RED-S terminology is it acknowledges some important things that weren't originally understood, or at least not well recognized. So one is that it affects men too. So again, typically we heard about the female athlete triad, but not so much the male athlete triad. 2, it recognizes the root cause, which is the energy deficit itself. And 3, it recognizes there are lots of physiological consequences to this, not just the typical ones of menstrual dysfunction and bone health decrements. So yes, those things can happen, but decreased immunity, decreased protein synthesis, so worse muscle building and maintenance, decreased metabolic rates, decreased cardiovascular function, decreased psychological health, and decreased exercise performance and recovery. So all these things then affect your ability to perform both in your practice schedule as well as your performance schedule for your athletics. Or if you're just someone who exercises a lot, it affects your ability to maintain that same level of exercise. And obviously it's bad for your health. A lot of these other things are health consequences. So what exactly is going on here? If you look at this graph over here, we have the first condition where the needs are met. All right, so this is someone who's not experiencing RED-S. So the caloric intake, this red bar, is equal to the energy required for physical activity and the energy required for resting physiology added together. So these two added together equals the caloric intake. So you're eating enough calories for your physical activity and resting energy needs. In these other two scenarios, both of these are situations where the person would likely be experiencing RED-S. And so both of them, you're going to notice that the energy for rest and the energy for physical activity added together is going to be greater than the caloric intake. But that can happen in two different ways. The first one is if you maintain your caloric intake. So let's say you were this person and you started increasing your physical activity, or you started physical activity and you didn't increase your caloric intake. So now your physical activity needs are greater, pushing up your total energy needs. But if you haven't met that with caloric intake, then you're going to eventually experience RED-S. If you do it through dieting, so that's this other situation here. So let's say you've maintained your physical activity and resting energy needs as you were before, but you have reduced your caloric intake. Usually this is done for weight loss purposes, and in some people it makes sense, but we're talking about athletes specifically here, or people who are already probably pretty lean. So if you reduce your caloric intake, now you are not meeting your energy needs and you are in a deficiency, you're in a deficit. So that is essentially what, again, relative energy deficit in sport means, or deficiency in sports mean. Both of these conditions would be conditions ripe for RED-S, where you can start having some or all of these symptoms over here. And there's additional symptoms not listed here. This is a very short list. So regardless of how you got RED-S, or the athlete you're working with, or someone you're working with, your client, it's something that you need to correct, and you need to get the energy balance back in check. So you either need to increase the caloric intake or decrease the physical activity, or a little bit of both, in order to get them back in some form of balance. In this video, I'm going to be discussing some basic recommendations for women who are exercising while pregnant. These are just the basic information. You really should be seeking information from your medical professional if you're watching this to try to get that information. And there are also some organizations out there that are helpful and produce research and recommendations on this topic. And I'll try to put a link in the description below this video on that. Generally speaking, exercise during pregnancy is okay if it is a normally developing pregnancy, which means you do need to be seeking regular clinical care and clinical checkups to make sure that it is a regularly developing pregnancy. For most women, the benefits of exercise far outweigh the risks of exercise for both the women that are pregnant and for the unborn child. All right, so consult your clinician prior to beginning or continuing exercise to make sure, again, that it is a normally developing pregnancy, and continue to get treatment throughout your pregnancy to make sure that it stays a normally developing pregnancy. Otherwise, some of these recommendations down here may not apply to that situation. Generally speaking, mild to moderate exercise of at least 3 days per week is recommended. Avoid exercise intensities that are very high and that are beyond the exercise intensities that were used prior to pregnancy. So if you did not exercise prior to being pregnant, you can still start exercise, but you probably want to keep it in the mild to moderate intensity range. People who were previously exercising before they got pregnant can continue their higher intensity exercise as long as they don't have complications. They'll likely need to back off a little bit towards the end, because whether there's complications or not, it will become much more challenging as body weight increases in body weight distribution. So the center of gravity changes. So you probably are going to have to decrease intensity at some point, but you don't need to do it ahead of those things happening. You should not do supine or prone exercise after the first trimester. So supine means laying on your back. That is going to cause the fetus in the womb to be putting a lot of pressure on your inferior vena cava and potentially compressing that, which is going to decrease blood flow around the body, both to you and to the fetus. So it's not something you want. You don't want to do prone exercise, that is laying on your stomach, because obviously you're then putting pressure on your stomach, which could potentially cause damage to the stomach and the fetus and the womb. So you don't want to do that. Avoid situations that require a lot of balance. Think cycling, for instance, because if you were to fall, so as you become in later and later stages of pregnancy, your center of gravity moves and your balance does change, and that can take some adaptation that probably hasn't occurred yet for most women because it's a pretty quick process. So if you were to fall, it is possible for you to injure your abdomen, which then could hurt the fetus, and that's something we want to avoid. You should generally stop exercise once you feel fatigued. Pushing yourself beyond the point of fatigue can potentially lead to complications that we want to avoid. When possible, non-weight bearing exercise is preferred. So think of swimming, for instance, because it's going to help support your body and you're not likely to fall and injure your stomach in exercise like swimming. Ensure you have adequate caloric intake. So that does not mean to excessively consume calories, but you do want to make sure that you are replacing the calories you burn during exercise. The goal is not weight loss during pregnancy, at least not typically. We want to avoid extremely hot weather and extremely hot, humid weather, especially, and make sure that we maintain hydration. Dehydration or excessive body heat can affect the fetus. We also want to make sure that once we are past the pregnancy that we resume our pre-pregnancy exercise routine in a gradual manner. So postpartum exercise routines should be should approach what you did pre-pregnancy, but you do need to give your body time to heal, and you want to make sure that you progress slowly so you don't end up with an injury or some sort of issue related to the postpartum period. One more note here about exercise during pregnancy: avoid anything where there's going to be a difference in the pressure placed on your body. So don't scuba dive, that increases the pressure placed on your body, and don't go to high altitude in order to exercise. That's going to lower the pressure on your body. Both of these can change the way our body tolerates exercise and also affect our ability to distribute blood around the body and oxygen around the body, which can affect, again, fetal development. As already mentioned, this was just a basic overview of exercise while pregnant, so make sure that you discuss this with a doctor. If you are somebody who are exercising while pregnant or considering starting exercise while pregnant, or if you are working with a client who is pregnant, make sure that you have conversations with their doctor and look up a more definitive source that has more information than this basic list that I gave you here.